Hi guys! So today we're going to talk about impulse control disorders. And the reason I'm bringing this subject up is because of the holidays coming up. And with dissociative identity disorder, you have these impulses that you have to learn to control. And with stress and holidays, that can be pretty intense. So my resources are going to be through this book here by Colin Ross. And the other one is going to be through the National Library of Medicine, which is www.ncbi.nih.gov. And I did a little research through mentalhelp.net. So in Colin Ross's book here, it states, impulse control disorders are always dissociative in nature. Impulses from outside the sphere of the executive self override the control of the executive self in a manner experienced as ego alien and ego diagnostic by the executive self. The impulse control disorders are classical examples of dissociative executive control. Dissociative executive control is occurring in the impulse control disorders, whether the cause is biological, physiological, or a combination of the two. Intermittent explosive disorder rarely occurs without comorbidity and a history of trauma. So it states here, the episodes are a form of dissociative flashbacks in which the past traumatic emotion and behavioral reactions are activated and intrude into the executive self. The verbal, visual, and cognitive elements of the past trauma are disassociated from the feelings and behavior, with intrusion of the feelings and behavior, but ongoing suppression of the visual, verbal, and cognitive elements. The intermittent explosions are triggered by environmental or internal cues, just like the episodes more commonly thought of as trauma flashbacks. So basically what Colin Ross is saying here is, let's say you're vacuuming and your vacuum gets something caught in it and it goes tink, 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 tink. Okay, remember this is just an example. Per se, back then in your past, that happened and there was a huge blow up with somebody and you got physically assaulted or hurt in some form severely. That can cause a flashback. So per se, today you're vacuuming and something gets stuck. All of a sudden you're going to feel this impulse of anger or impulse of fear, and it's going to trigger an alter to react in an aggressive manner. So that's what they're talking about here. It's basically learning to control that impulse. And last, it says treatment outcome. In trauma cases with extensive comorbidity, the impulse control disorder will respond to trauma therapy, assuming there is a real commitment and work to the therapy. So I have experienced this issue. Sorry. So basically, I have alters that get very upset and very angry, fighting very triggering situations like SA abuse, things like that. And because of the commonality of my trauma throughout my whole life, towards the middle of my teenhood/adulthood, I would fight back, and I'd fight back with such aggression that there was no control over me. So now with the therapy that I'm doing today, let's say I have an alter come out and basically cuss at my therapist, which has happened numerous times. My therapist will respond with a very calm voice, a very caring voice, and a very loving voice. Basically saying, you can be mad, you can be angry at me, you can cuss at me all you want, I'm not going anywhere, and I'm going to work with you. And that's how the process is changed. So next, here's the simple definition from Google. It says, impulse control disorders, known as ICDs, are what they sound like. They are a group of behavioral conditions that involve an inability to control impulses and behaviors, like angry outbursts and destroying property. Therapy and adapting parenting strategies can help manage ICDs. But now the question is, if you're an adult, how do you do that with teen and child alters? So here's the abstract of it. ICDs are categorized by urges and behaviors that are excessive and or harmful to oneself or others and cause significant impairment in social and occupational functioning, as well as legal and financial difficulties. ICDs are relatively common in psychiatric conditions, yet are poorly understood by the general public, clinicians, and individuals struggling with the disorder. Although ICD treatment research is limited, studies have shown ICDs may respond well to pharmacological treatment. That's a big word. This article presents a brief overview about the clinical characteristics of ICDs and pharmacological treatment options for individuals with ICDs. So the APA wrote this little small article in 2000, and it states ICDs are relatively common among adolescents and adults carrying significant morbidity and mortality, and can often be effectively treated with behavioral and pharmacological therapies. A study of 791 college students found that 10.4% met criteria for at least one lifetime ICD, demonstrating the common nature of these disorders in the general population. The intent of this review is to provide an updated clinical picture of the previous mentioned ICDs and present evidence of potential pharmacological treatments for these disorders. So here it states ICDs have 4 features. 1 is repetitive or compulsive engagement in a behavior despite adverse consequences. 2, diminished control over the problematic behavior. 3, an appetitive urge or craving state prior to engagement in a problematic behavior. And 4, a hedonic quality during the performance of the problematic behavior. These features have led to a description of ICDs as behavioral addictions. ICD symptomology may worsen with co-occurring disorders, and co-occurring disorders may interfere with treatment outcomes. Most pharmacological trials have excluded individuals with co-occurring primary axis 1 disorders. With such high proportions of ICD patients enduring co-occurring conditions, future clinical trials should investigate how specific comorbidities distinctly influence treatment results. These findings will advance knowledge about the efficiency of the treatment for those with co-occurring problems. So what I found interesting is there wasn't much on the treatment of ICDs in dissociative identity disorder, but I did find an article about it. And it states here, people with personality disorders tend to exhibit problems with impulse control. These problems can manifest as either over-controlled or under-controlled impulses. Under-controlled impulse control is commonly called a lack of impulse control. In the same manner that people with personality disorders may have problems with over or under-controlled effective emotional regulation. They also tend to have problems regulating their impulses. Here too, we can think of impulse regulation along a continuum ranging from over-control to under-control, with healthy personalities falling somewhere in the middle between these 2 extreme poles. Consider the issue of self-control and the need for a healthy balance between over-control and under-control. On the one hand, we need to control our impulses and to consider the consequences of acting upon an impulse. Having considered the consequences, we then decide how to act accordingly. We determine whether to allow ourselves to indulge the impulse or whether to inhabit it. The inhabitation of certain impulses enables us to behave in ways that are both responsible and socially acceptable. Therefore, inhabitation of our impulses serves to promote our success in both relationships and in the workplace. 2 areas of particular concern are aggressive and sexual impulses. If we were to act on our every aggressive or sexual impulse, we would easily get ourselves into a great deal of trouble. On the other hand, the over-control of impulses leads to its own set of problems. A certain amount of carefully considered risk-taking is necessary to reap the benefits of creative expression, rewarding relationships, and successful problem-solving. Some amount of risk-taking is part of the excitement, fun, and spontaneously associated with an enjoyable life. With too much impulse control, we end up feeling restricted, bored, and dull. With too little, we can get ourselves into a great deal of trouble. Clearly, a balance between these two extreme poles of over and under control would represent a healthy personality. People with personality disorders are distinguished by the rigidity of their pattern of over and under control, and the severity and persistence of their impulse control problems. Rigid and persistent over-control of impulse can manifest itself as inhabitation, reluctance to do anything that involves any type of uncertainty or risk, reluctance to start new things or try new activities, and over-consciousness or scrupulousness, whatever that means. Rigid and persistent under control can manifest itself as reckless and a disregard for rights and needs of other people. This pattern can lead to troublesome or dangerous problems such as drug use, dangerous or risky sexualization, overspending, assault, or self-injury. So, the bottom line is what they're saying here is with a personality disorder, you're going to have, especially with dissociative identity disorder, you have alternative states. They are still you. They're still in the same body. It's just your mind shuts down in one area and lights up in another. Okay? And so basically, while this spot's napping, this one wakes up. And let's say it's a teen alter. And they're aggressive. And they self-harm you. And they have all these issues. In therapy, the idea is to work with their impulses, to control that behavior and to change it. Give them a new aspect of how their life is, how old they are. And a lot of times in therapy, I had talked about this before, my therapist will make the alters look at the hands, look at the face, realize the age of the body, how long they have been there and why. And then after a while, with a certain amount of therapy, she will engage with them new behaviors. So per se, I'll give you an example. My alter 16 loves singing, but she's also very aggressive. She likes to fight, things like that. When alter 16 would have these fits, my therapist would work with her to give her new assignments. So it got to be where she would learn to express her anger in a calm manner. That's not easy. Not easy. So basically, changing the behavior to where she can stay at her point and put up a boundary of what she likes and dislikes without aggressively going after somebody. It's the same with the self-harm. Self-harm is also an issue where you can work with an alter to find a way to aggress that anger out. So I found it interesting that some of the alters would hit things, throw things, but make sure it's in a safe place to feel that adrenaline rush without harming the body. Okay? So this holiday season, I'd like you to really think about these things you just learned and work with your therapist on controlling that impulse, putting up boundaries. Boundaries are vital, very vital for holidays. Especially if you got to go to a holiday, limit your time having to be there, limit your time like going early or going later when less people are there. This gives your alters a kind of to stay back and let you express yourself. The idea is to try to stay focused, try to stay grounded as long as possible while doing these outings. Holidays can be very triggering for people, and alters can ruin that or sometimes help that. But again, the idea is to heal from it and to be able to stay and to heal yourself. So I hope you found this video useful. You're more than welcome to use it in your therapy. And that's all I pretty much have today. Loves. Bye.